Hi, I'm Dr. Joshua Richter. I'm an associate professor of medicine at the Tisch Cancer Institute, Icahn School of Medicine at Mount Sinai, and the director of myeloma at the Blavatnik Family Chelsea Medical Center at Mount Sinai. Here at ASH 2024, and really excited to present our data on Cevostamab in relapsed refractory multiple myeloma. Cevostamab is a novel target bispecific antibody, so I think a lot of the people that watch these channels are really inundated with all the great data we've had so far with bispecific antibodies in myeloma. We currently have 3 FDA-approved ones, 2 that target BCMA, and a third one that targets GPRC5D. Cevostamab has a brand new target called FcRH5, which, just like those other 2 targets, is located on all malignant plasma cells. So as a bispecific antibody, it's what I call Thunderdome. Remember the old-fashioned Thunderdome, 2 men enter, 1 man leaves. So as a bispecific antibody, it grabs onto the cancer cell, grabs onto the T cell. Both cells enter Thunderdome, and only the T cell emerges victorious at the end. So we're presenting the updated data on our phase 1 study. This was a dose-finding study, and when it comes to bispecific antibodies, it's more than just the milligram of the dose, but how frequently to give it and what type of step-up. So this drug has been given in a variety of step-ups with 1 step-up, single step-up dose, double step-up, and triple step-up, and at varying doses. So we've settled on 160 milligrams as the dose to move forward with. And across all the different cohorts, 167 patients were treated at 160 milligrams. But what we're really focusing on here is the 30 patients that got 160 milligrams with a triple step-up. These patients were very heavily pretreated. In those 30 patients with a triple step-up at 160 milligrams, they had a median of 7.5 prior lines of therapy. And in modern-day myeloma, that means you've had everything. And what we saw is for the overall cohort, it had about a 44% response rate. But if you did not have a prior BCMA therapy, that went up over 60%. The major toxicities causes low blood counts. The majority of this is reversible, and infection rate actually seems to be better than the BCMA. So grade 3 infection rate was only about 19%. For patients that got a partial remission, their median duration of response was 10.4 months, but a VGPR or better got you over 21-month progression-free survival. Now, in my mind, one of the best parts is that this is fixed duration therapy. Once you get stepped up, you get a dose of Cevostamab once every 3 weeks for 17 cycles, which is about 1 year of therapy, and then you stop. And we have a number of patients now years off of therapy, in remission, in heavily relapsed myeloma, which is amazing. And one of the biggest predictors of being able to maintain that remission off of therapy is if you got a stringent CR or better. So really excited about this data, and we're moving forward with it and looking forward to future studies with combinations, such as combinations with pomalidomide and other anti-myeloma therapy.